Good morning everybody, and today what we're going to discuss is the microvascular complications of diabetes. This is lecture 4 in your lecture series of diabetes, so let's get going. Basically, microvascular complications result because of hyperglycemia in the diabetic patient, and to prevent them we want to get the HbA1c to less than 7% in most patients. Obviously this is not optimal in the elderly. Complications that we're going to discuss in this lecture include diabetic eye disease, diabetic kidney disease, and diabetic neuropathy. Right? So let's discuss diabetic eye disease. Diabetic eye disease is the leading cause of visual impairment in the developing world, and it's made up of diabetic retinopathy, diabetic macular edema, and of course cataracts. Right? Diabetic retinopathy is by and large preventable and or treatable. In other words, it's preventable by reducing the patient's glycemic levels. Cataract surgery is on the increase, particularly in the developing world, and of course people will therefore have less cataracts. It's imperative that patients are appropriately screened and referred to an ophthalmologist to detect diabetic eye disease. So what are the risk factors for diabetic eye disease? Firstly, the duration of diabetes. So the longer you have diabetes, the more likely you are to, of course, have diabetic eye disease. When it comes to glycemic control, the better your glycemic control, the less likely you are to have diabetic eye disease. The worse your glycemic control, that means the higher your HbA1c, the more likely you are therefore to have diabetic eye disease. If your blood pressure is too high, you are more likely to have diabetic eye disease. If you have dyslipidemia, you are more likely to have diabetic eye disease. And if you have diabetic kidney disease, you're also more likely to have diabetic eye disease, because they're all related. It probably means that your blood sugar is not well controlled or was not well controlled for a significant period of time. So how do we screen? Well, patients and family members must be educated regarding diabetic retinopathy, right? And screening should happen at the time of diagnosis in a type 2 diabetic patient and 5 years after diagnosis in a type 1 diabetic patient. Now you might wonder why. Well, the truth is that if you can remember back to your STEPS lectures and what we discussed, most type 2 diabetic patients are actually only diagnosed 5 to 10 years after they actually first develop diabetes, and it's often an incidental finding. In other words, the person ends up in a hospital with an MI and suddenly you do their blood sugar levels and you find out, oh wow, they're actually diabetic. Or the person has hypertension and now you're doing their blood sugar levels and you find, oh wow, they're actually diabetic as well. So it's mostly an incidental finding at that point because they don't have overt symptoms of hyperglycemia, unlike type 1 diabetics who have overt symptoms of hyperglycemia, for example polyuria, polydipsia, polyphagia, weight loss, etc. So screening should ideally be done by a trained optometrist or ophthalmologist. All screening encounters should begin with a clinical evaluation, an emphasis on glycemic control, understanding the duration of diabetes, looking for other comorbid conditions like hypertension and dyslipidemia, as well as drug therapy and a general ocular history. Visual acuity tests are what we will generally use in a resource-poor setting like South Africa. There is some debate, however, as to whether visual acuity tests are good enough, but at this point, this is just what we have. So, a trained healthcare professional can assess visual acuity. Right? Refracted visual acuity examination using a 3 to 4 meter visual acuity lane with a high contrast visual acuity chart can be used. Presenting visual acuity examinations using a near or distance chart and a pinhole if visual acuity is reduced, and we've discussed how to do all of this when we discussed how to examine the eye. And then also presenting visual acuity examination using a 6/12 equivalent handheld chart consisting of at least 5 standard letters or symbols and a pinhole option if visual acuity is reduced. Now, if you're going to use the handheld chart, a visual acuity of less than 6/12 is definitely requiring a referral to an ophthalmologist. Now, other screening methods that are mostly done by ophthalmologists and optometrists include fundus photography screening, indirect ophthalmoscopy, and direct ophthalmoscopy. Fundus photography screening is probably the best because it gives you a permanent record of the retina at that particular point in time. Essentially, it's a digital image of either 35mm film or Polaroid instant prints. Alright, and it's screening with a mobile camera, which means that it is possible to do it in primary care in South Africa. And then the retinal photography is effective, acceptable, and cost effective. And once the photography is done, you just need an expert to evaluate it. And what they've done nowadays is they've developed apps where the nurse or the person in the primary care setting can actually take a photo of the fundus and send it via the app to an ophthalmologist or a trained optometrist to look at and to give them feedback regarding the person's retina. So indirect ophthalmoscopy is via slit lamp ophthalmoscopy. We're not going to discuss this in too much detail. Direct ophthalmoscopy is where you will first dilate the pupil and you use atropine eye drops to do that, and it's the least reliable method. If I were to say what is the most reliable method, I would suggest fundus photography, and that's because you will have a permanent record to look at each time you need to actually do the screening. Now, how do we classify diabetic eye disease? Well, if there is no apparent diabetic retinopathy and there are no abnormalities, then we'll say that there are no apparent diabetic retinopathy. If we only find microaneurysms, we'll say that the person has mild non-proliferative diabetic retinopathy. If they have microaneurysms and there are dot and blot hemorrhages, there's certain hard exudates, cotton wool spots, but less than what we would consider severe non-proliferative diabetic retinopathy, then they have moderate non-proliferative diabetic retinopathy. If they have moderate non-proliferative diabetic retinopathy with either some kind of intraretinal hemorrhage, some kind of definitive venous bleeding, some kind of intraretinal microvascular abnormalities in at least one quadrant, and no signs of proliferative diabetic retinopathy, then they have severe non-proliferative diabetic retinopathy. And then of course there's proliferative diabetic retinopathy, where you will find neovascularization and vitreous hemorrhage as well. And in this case, they would have severe severe non-proliferative diabetic retinopathy with either neovascularization or vitreous hemorrhage, and in that case, we consider it to be proliferative diabetic retinopathy. Now, how about diabetic macular edema? And these are the findings that would be on dilated ophthalmoscopy. All right. So, no diabetic macular edema. Sorry, as I was saying, when there's no diabetic macular edema, right, then you will have no retinal thickening or hard exudates in the macula itself. When there is non-centrally involved diabetic macular edema, then you will have retinal thickening in the macula that does not involve the central subfield zone that is 1 millimeter in diameter. And where there is centrally involved diabetic macular edema, you will have retinal thickening in the macula that does not involve the central subfield zone that does involve the central subfield zone. So it does involve the central subfield zone that is 1 millimeter in diameter. Right, now you will all remember where the different structures of the eye are, and we've already discussed this. So let's look here at the difference between non-proliferative and proliferative diabetic retinopathy. And clearly you can see that this here is a form of non-proliferative diabetic retinopathy. We've got our hard exudates here, we've got our microaneurysms here, we've got our hemorrhages here, right? But we don't have any neovascularization or growth of new blood vessels, as you can see. If you look here, there's no neovascularization at all. Comparatively, look at the neovascularization that is occurring here. And automatically then you can tell, this is proliferative diabetic retinopathy. right? Because we can see the neovascularization. So it has all the hallmarks of non-proliferative diabetic retinopathy in terms of the hard exudates. You've got your microaneurysms there, but your hemorrhages as well, as you can see here. Sorry. That's your hemorrhages. But it's also got the neovascularization, and that essentially is the main difference that we are discussing. So, now classifying the type of diabetic retinopathy or diabetic macular edema tells you whether or not to refer, when to refer, and when to rescreen. So if there is no apparent diabetic retinopathy or mild non-proliferative diabetic retinopathy with no diabetic macular edema, then what you can do is re-examine every 1 to 2 years and there's no referral required. If, however, there is mild non-proliferative diabetic retinopathy, you should screen every 6 to 12 months, but referral is still not required. Once you get to moderate, severe, and of course proliferative diabetic retinopathy, then always referral is required, and screening should be, if it's moderate non-proliferative, every 3 to 6 months, if it's severe non-proliferative, every 3 months, and if it's proliferative diabetic retinopathy, less than within a month. Severe non-proliferative is less than 3 months, and proliferative is less than 1 month. My mistake. Now, with diabetic macular edema, right, you always require referral to an ophthalmologist, right, and re-examination should occur. For classification, right, you should re-examine, and then of course on the next visiting schedule you re-examine again. If it's non-centrally involved, a re-examination should occur every 3 months and referral is required. If it's centrally involved, every month you should re-examine and referral is required. Now, what are the management options for diabetic eye disease? Well, essentially what we can use here is pan-retinal laser photocoagulation, which is commonly used, and 2 studies, the DRS and the EDTRS, have all showed that this particular form of laser therapy to the eye itself is actually efficacious and very useful. The other alternative is the epithelial growth factor receptor agents, the antivascular epithelial growth factor receptor agents, or the VEGFR agents, anti-VEGFR agents. And ranibizumab is the one. It's found to be non-inferior to laser photocoagulation after a 2-year follow-up or at a 2-year follow-up. And patients do not require patients with photocoagulation don't require as many treatments. Patients who take ranibizumab require more treatments, obviously. And of course, anti-VEGF therapy, right, improves vision and has replaced laser photocoagulation for the majority of patients with diabetic macular edema. It's worth noting that ranibizumab tended to have less peripheral vision loss, fewer vitrectomy surgeries for secondary complications from proliferative disease, and a lower risk of developing diabetic macular edema. Most patients require monthly administration of the intravitreal therapy with anti-VEGF agents during the first 12 months, with fewer injections being required or needed in the subsequent years to maintain remission from centrally involved diabetic macular edema. Now, the adjunct therapy is extremely important, right? It's important to lower blood pressure, as lowering blood pressure has been shown to decrease retinopathy progression. Ideally, you want to target your systolic blood pressure to less than 140. Targeting systolic blood pressure to 120 or less doesn't impart any additional benefit. ACE inhibitors and ARBs are both effective in the treatment of diabetic retinopathy, and retinopathy progression may be slowed down by the addition of fenofibrate, particularly in patients with non-proliferative diabetic retinopathy. But the question is, most of this is going to happen at secondary and tertiary care level, particularly for laser photocoagulation and anti-VEGF therapy, and even for that matter when you're referring on, alright? So what should you be doing at a primary care level? Well, the truth is that at a primary care level, your role is essentially to optimize glycemic control, blood pressure, and of course lipid control to limit as much as possible the progression of diabetic retinopathy. It's worth bearing in mind that when you intensify glycemic control, this may result in an acute worsening of diabetic retinopathy, right? Particularly, people might start to get severe blurred vision. Therefore, patients may benefit from treatment for significant diabetic retinopathy prior to intensifying, obviously, their glycemic control. But good glycemic control should not unnecessarily be delayed, as the benefits of good glycemic control outweigh the risks completely. And in addition to that, patients with diabetic retinopathy are likely to have other microvascular complications, and patients should be screened for diabetic kidney disease and diabetic neuropathy as well. Now, this is an example of what laser photocoagulation does to the eye. Essentially, what you do is you essentially kill portions of the eye, so the eye requires less oxygenation as a result. Now, pregnancy. Pregnancy is associated with rapid progression of diabetic retinopathy. Pre-existing type 1 or type 2 diabetics who are planning pregnancy or who have become pregnant should be counseled about the risks of development and progression of diabetic retinopathy. Rapid implementation of intensive glycemic control in the setting of retinopathy is associated with early worsening of retinopathy. Particularly, these patients will always complain to you about the blurring of their vision. Women who develop gestational diabetes do not require eye examinations during their pregnancy, and this is because they are unlikely to suffer from diabetic retinopathy during their pregnancy as well. Right, exercise. In the presence of proliferative diabetic retinopathy or severe non-proliferative diabetic retinopathy, vigorous aerobic or resistance exercise may be contraindicated because there is a risk of triggering vitreous hemorrhage or retinal detachment. This includes jumping, jarring, moving the head up and down, etc. So what are the basic recommendations? Diabetic eye disease is the leading cause of visual impairment, and screening individuals for diabetic retinopathy is indicated for all patients with type 2 diabetes. And remember, for type 2 diabetes, we screen at the time of diagnosis. For type 1 diabetes, we screen 5 years after diagnosis, and then depending after that on the results of our screening, we then decide how often we need to still screen the patients. We need to optimize glycemic control, blood pressure control, and lipid control to reduce the risk of progression of diabetic retinopathy. These are all A-grade recommendations. So some B-grade recommendations is screening at the time of diagnosis for type 2 diabetes, and patients without retinopathy or diminished visual acuity should be screened every 1 to 2 years. So like we said, there's no referral required for a person who has no diabetic retinopathy, but they must be screened every 1 to 2 years. Patients with mild non-proliferative diabetic retinopathy obviously need to be screened every 6 to 12 months, and of course referral is still not required. Right, patients should have their visual acuity assessed. Now, like I told you, there's some debate over this particular statement itself, but in general speaking, right, we would say that patients should have their visual acuity assessed, particularly in resource poor settings, right? Remember that a score of less than 6/12 is what we would use as referral to an ophthalmologist. The preferred method of screening is fundal photography or dilated indirect ophthalmoscopy. Fundal photography is by far the easiest one because it gives you a picture of the person's actual eye. Urgent referral to an ophthalmologist is indicated where there is a sudden loss of vision, retinal tear or detachment, proliferative diabetic retinopathy, or severe diabetic macular edema. Pregnancy may be associated with a worsening of diabetic retinopathy. Patients should be counseled and screened for diabetic retinopathy prior to pregnancy or in their first trimester. I think equally is worth saying that this does not apply to gestational diabetes. The patient must have diabetes prior to pregnancy, so either have type 1 or type 2 diabetes. Right, let's move on to diabetic kidney disease now. Now, CKD and DKD. CKD or chronic kidney disease is defined as the presence of kidney damage, right? Usually detected as urinary albumin excretion of greater than 30 milligrams per day or equivalent, or decreased kidney function, which is an EGFR of less than 60 mL per minute per 1.73 square meters. And most importantly, it must be there for 3 or more months, irrespective of the cause. Now, kidney disease that is directly attributable to diabetes is known as diabetic kidney disease. In South Africa, hypertension and of course type 2 diabetes are the dominant causes of kidney failure or chronic kidney disease. Prevalence of DKD in South Africa is roughly between 14 to 16%, and 30.4% of these patients, 30.4% of patients who require renal replacement therapy have diabetes. So, screening annually with no transient causes of albuminuria or you need to screen annually when the patient has no transient causes of albuminuria or low EGFR present. In patients with type 1 diabetes, annually from the post-pubertal age, annually in people who are post-pubescence, you should screen for diabetic kidney disease, and any individual with a duration of type 1 diabetes that is longer than or equal to 5 years should be screened annually. For patients, of course, with type 2 diabetes, you screen at the time of diagnosis, and of course you screen annually thereafter. And how do we screen? We use random urine albumin to creatinine ratio, serum creatinine to calculate EGFR, and urine albumin excretion. And how do we interpret these results? Well, if the person is normal to mildly increased albuminuria, you will have albumin excretion ratio of less than 30 milligrams per day and a urine albumin to creatinine ratio of less than 2 milligrams per millimole. When they have a moderately increased, you will have anywhere between 30 to 300 and 2 to 20 milligrams per millimole. And if they have severely increased, here you may have it may be subdivided into nephrotic and non-nephrotic, and there may be differential diagnosis, management, and risk predictions with each. And the albumin excretion ratio will be greater than 300, and the urine albumin to creatinine ratio will be greater than 20. And this is something that you should probably know for a testo exam, right? How to distinguish one from another, and it's something that could definitely come up. Another thing to bear in mind is the stages of chronic kidney disease, which I'm sure you're already well aware of. And EGFR of greater than 90 mL per minute per 1.73 square meters is generally considered normal or high EGFR. Once you are less than 90, that's when either you're going to have very mildly decreased EGFR, so an EGFR stage 2, that's 60 to 89. then mild to moderately reduced EGFR or stage 3A of CKD, that's 45 to 59. And then stage 3B of CKD is moderately to severely decreased EGFR, it's 30 to 44. And then severely decreased EGFR is 15 to 29, that's at stage 4. And then of course at stage 5 you'll have less than 15, and that is the stage at which dialysis is definitely required. Right, so screening for CKD in adults, right? You need to screen annually when no transient causes of albuminuria or low EGFR are present, and patients with acute kidney injury or non-diabetic kidney disease is not suspected. In type 1 diabetes, you need to screen annually in patients who are past puberty, and of course, any individual with a duration of diabetes greater than or equal to 5 years in the case of type 1. In type 2, at the time of diagnosis, and annually thereafter. So what will you do? You order a random albumin to creatinine ratio and of course a serum creatinine for EGFR. If the albumin to creatinine ratio is greater than 2 milligrams per millimole, so in other words, you're sitting here, you had moderately increased, it's anywhere between 2 to 20, or the EGFR is less than 60, so you're sitting here with mild to moderately decreased EGFR, right? Then what you'll do is then you'll do you'll then do a random urine albumin to creatinine ratio and see whether or not it's greater than 20 milligrams per millimole, right? If it is greater than 20 milligrams per millimole, right, then what you'll say is most probably the person has CKD. If it's still less than 20 milligrams per millimole, you'll order your serum creatinine and EGFR in 3 months, and to repeat urine albumin to creatinine ratios performed over the next 3 months. And at 3 months, if of course the EGFR is still less than 60 and 2 out of the 3 ACRs is definitely indicative of and 2 of the 3 ACRs is greater than 2 milligrams per millimole, then the person most definitely has DKD and CKD, guaranteed, right? So once you've established the diagnosis here of CKD, you then order urine dipstick and microscopy. Now the reason you'll do that is you want to exclude all the potential other causes of CKD, right? And then if CKD in the and then if none of these potential causes are the cause of the CKD, right, such as infection, for example, you'll then say that the cause is due to DKD and you'll treat as DKD. If you find something that may be the cause, like infection, for example, then you'll say it's as a result of non-diabetic kidney disease and you'll treat it as such. If the albumin to creatinine ratio, and this is very important, if the albumin to creatinine ratio or the EGFR, so if the EGFR is still more than 60 and the albumin to creatinine ratio is still less than 2, and so there's no evidence then of potential chronic kidney disease, then at that point there's no evidence of chronic kidney disease and you will rescreen in 1 year. So screening. In screening, it's important to exclude transient causes of albuminuria, and that includes recent strenuous exercise, menstruation, fever, UTIs, pregnancy, uncontrolled heart failure, and of course acute severe elevations in blood pressure or blood glucose. And I think it's worth also pointing out that you must differentiate between whether or not the patient has CKD or AKI. If the patient has acute kidney injury, you will not see a progressive decline in the EGFR or a consistent decline in the EGFR, or the EGFR still being less than 60 at your 3-month follow-up. And your albumin to creatinine ratio will either stay the same or will get worse. If your albumin to creatinine ratio stays the same at less than 2 and doesn't and gets worse, then you can say the person is CKD, not AKI. If, however, at the 2-month period you see an increase in the eGFR and a decrease in the albumin to creatinine ratio, then it's most likely that the treatment that you've given them in some way, shape, or form has actually helped them, and it's not necessarily going to be CKD. Right. Other things that can cause transient increases in albuminuria include pregnancy, uncontrolled heart failure, and acute severe elevations in blood pressure or blood glucose. Low eGFR can be as a result of dehydration or hypervolemia. Right. Acute renal failure on clinical grounds before each screening and urine dipstick testing can also be a reason why you'll get some of these results. So how do we prevent DKD? Well, prevention of DKD is primarily through tight glycemic control, right? The problem with tight glycemic control, as I am sure you all well aware of, is that there is an increased risk of hypoglycemia, and unfortunately there is a lack of evidence for tight glycemic control, particularly in the elderly populations, and whether or not this tight glycemic control will actually help prevent microvascular complications or macrovascular complications as well. So there is no firm evidence for specific blood glucose targets, and this is particularly the case in the elderly. And then there's a lack of RCT data for tight glycemic control in the elderly patients, like we've discussed. Right? Intensive glycemic control can slow down the progression of DKD in type 2 diabetes, as we've seen particularly in the younger type 1 population, but also in the type 2 population, who are generally younger. Cochrane review concluded that ACE inhibitors reduce the risk of new onset, moderate and severe albuminuria with similar benefits in patients with or without hypertension, and ARBs only seem to work in high risk patients to prevent DKD. So essentially, once a person has DKD, what you should be prescribing them is an ACE inhibitor, because an ACE inhibitor seems to particularly if they have moderate to severe albuminuria, right, they tend to benefit from the use of ACE inhibitor therapy. Additionally, their current diabetes therapy may require dose adjustments. Metformin, you cannot use it an eGFR of less than 30, and once the eGFR is less than 60, it requires dose adjustment. Gliclazide is, of course, the preferred sulfonylurea, particularly gliclazide MR, as we've discussed, and no dose adjustment is generally required for that one. When it comes to bioglitazone as well, while it must be used particularly under under specialist supervision, no dose adjustment is required, and can be used in stage 3 and 4 CKD or kidney transplant, provided the person is not a fluid retaining patient, obviously. Right. Lowering blood pressure is the most effective strategy in preventing end-stage renal disease, in other words, an eGFR of less than 30 in patients with DKD. Progression of DKD in patients can be slowed by either an ACE inhibitor or an ARB. Right? Risk of cardiovascular disease is increased with albuminuria, and ACE inhibitors should be the first line therapy agent that should be used in patients with established albuminuria, and this of course is irrespective of their blood pressure. The combination of ACE inhibitors and ARBs are not recommended, and the reason for that is that the combination of ACE inhibitors and ARBs to prevent the progression of DKD is not at all something you should be doing, because there is an increased risk of hyperkalemia, and of course renal dysfunction. And a recent meta-analysis has showed that the most effective strategy to prevent end-stage renal disease in patients with established DKD is by lowering their blood pressure with either an ACE or an ARB, while monotherapy with an ARB is only effective when it's quite severe. Unfortunately, no blood pressure lowering strategy prolongs survival in adults with diabetes and kidney disease. Any benefit of combining ACE inhibitors with ARB therapy obviously can lead to potential harms, and therefore is not something we should be looking at, right? And at this stage, a combination of ACEs and ARBs should definitely not be used in DKD. Okay, the initiation of ACE inhibitor therapy in patients with diabetes and a serum creatinine level greater than 124 micromoles per liter is suggested, and of course this is associated with acute increases in serum creatinine levels by up to 30%, but this generally stabilizes within the first 2 months of ACE inhibitor therapy and long-term renal function is preserved. There is, however, a significant increase in potassium and creatinine levels, which can be an indication that the person actually has bilateral renal artery stenosis. And bilateral renal artery stenosis is a contraindication for the use of ACE inhibitor therapy. Right? Serum creatinine and potassium levels must be monitored for 1 to 2 weeks after initiation of RAS blockers. This includes ACE inhibitors or ARB therapy, either one. Similarly, if you have a significant increase in potassium and creatinine levels after you start ARBs as well, you must take into account that there is the potential for bilateral renal artery stenosis there as well, and you must investigate that. Right, now, something that's changed over the past couple of years. Before, what we used to have is we could only use ACEs or ARBs, and some people were giving ACEs and ARBs together, which we've just discussed. Doesn't necessarily have any particular mortality benefits and may actually increase the risk of mortality as well. Either way, right? Something that has definitely changed now is our newer studies that we've done on the GLP-1 analogs and of course the SGLT2 inhibitors. So the SGLT2 inhibitors and the GLP-1 analog should be considered in patients with type 2 diabetes and chronic kidney disease who require add-on therapy to metformin. And here the SGLT2 inhibitors, in my opinion, take a lot of precedence because they reduce the risk of CKD progression. They reduce CVD events, particularly if we're talking about empagliflozin. Right, and of course they are not associated with significant hypoglycemia. Large cardiovascular outcome trials in type 2 diabetes are those with high risk for cardiovascular disease, and those with pre-existing cardiovascular disease examine kidney effects as a secondary outcome. And generally speaking, empagliflozin and liraglutide reduce the incidence and worsening of nephropathy. So those are your options. Now remember that liraglutide is your GLP-1 analog, and of course your empagliflozin is your SGLT2 inhibitors. Now it's worth noting that canagliflozin and liraglutide seem to work better in patients with established chronic kidney disease. So it's worth also taking into account that several large clinical trials of SGLT2 inhibitors have actually focused on advanced chronic kidney disease, and the assessment of primary renal outcomes are either completed or they are ongoing at the moment. So the Credence trial, which used canagliflozin, compared it of course to and compared it to a placebo in patients in 4,401 adults with type 2 diabetes with a urine albumin to creatinine ratio of 300 milligrams per gram of creatinine and a mean EGFR of 56 mils per minute per 1.73 square meters with a mean albumin urea level of 900 milligrams per day had a primary composite outcome of end-stage renal disease, doubling of serum creatinine, or renal or cardiovascular death. And it was stopped early because of the positive efficacy of giving canagliflozin to these patients, where there was a 32% relative risk reduction in, of course, the development of end-stage renal disease compared to the placebo. Now, some of you are going to say, but hold on, Mohammed, you told us in the other lecture we shouldn't start SGLT2 inhibitors in patients with an EGFR of less than 60, and we shouldn't continue it in patients with an EGFR of less than 45. And you said that's because there's no benefit. Yes, that's true. There's no glycemic benefit in patients. However, there is a benefit beyond the glycemic. And what has happened is studies have actually showed us, right, particularly the newer studies, right, have shown us that that the cardiovascular benefit of SGLT2 inhibitors and of course the renal benefit of SGLT2 inhibitors are not blunted even if the EGFR is less than 45. And you can actually go to an EGFR of 30 before the cardiovascular benefit and the renal benefit is actually blunted. And so what I'm saying to you essentially is that these drugs may not help significantly, the SGLT2 inhibitors in particular, may not have significant effects on a patient's glycemic control at that point, but you may not be using it for their glycemic control anymore. You may instead be using it for their renal disease or to prevent cardiovascular outcomes. And I think that that is very important and worth me pointing out. So your options here are either canagliflozin, empagliflozin, or liraglutide, because they not only reduce cardiovascular events, but they also seem to reduce renal events. Right, so when do patients require referral to a nephrologist? Referral to a nephrologist should be done when there is chronic progressive loss of kidney function, when the albumin to creatinine ratio is persistently above 60 milligrams per millimole, if the EGFR is less than 30 mils per minute per 1.73 square meters, if they are unable to remain on renal protective therapy due to adverse effects such as hyperkalemia or greater than 30% increase in serum creatinine levels within 3 months of starting an ASO and ARB, or you are unable to achieve blood pressure targets, right? In that case, you could refer them to a specialist in hypertension, so someone like a cardiologist may be a definite referral in that scenario. Nutrition. Now nutrition, right? For patients who are on non-dialysis dependent CKD, dietary protein intake should be maintained at roughly 0.8 grams per kilogram of body weight per day. Right? Restriction of salt intake to less than 2,300 milligrams per day or 6 grams of table salt is useful in controlling blood pressure and cardiovascular risk. Restriction of dietary potassium levels may be necessary in patients to control their serum potassium levels. Patients on dialysis may require higher dietary protein intakes, and this should be considered. Dietary restrictions must be individualized, and this is especially true in patients who are on dialysis, right? And that is because malnutrition is a major problem in some dialysis patients. Exercise. Physical activity can acutely increase urine protein excretion. This is something that you should know from your lectures on the kidney itself. And of course, there is no evidence that vigorous exercise will in any way increase the progression of DKD, which is why we still suggest that the person does your vigorous intensity or your moderate intensity exercises even if they have DKD. It's not something you can necessarily say for diabetic eye disease, because we want to worry about the risk of vitreal hemorrhage there. And of course, there is no need for specific exercise restrictions in patients with DKD. So what about diabetic neuropathy now? Diabetic neuropathy are a heterogeneous group, so they are a vast group of disorders with a number of diverse clinical conditions. Diabetic neuropathy is the diagnosis of exclusion. So early recognition and appropriate management of neuropathy in diabetic patients is of paramount importance, and roughly 50% of patients will have what we call DPN or diabetic peripheral neuropathy. So what is diabetic peripheral neuropathy, right? And how do we screen for it? Essentially, diabetic peripheral neuropathy is essentially burning or tingling sensation in the peripheral parts of the body, so such as the fingers or the toes. There may even be loss of sensation in the fingers or the toes, and that is something that happens particularly in diabetic patients. In type 1 diabetic patients, you should only screen for peripheral neuropathy, similar to what we've discussed before, when they have a 5-year history or longer of type 1 diabetes. Comparatively, those patients with type 2 diabetes must be screened at the time of diagnosis and then annually. Symptoms of DPN vary accordingly with the class of the nerve fibers that are involved, and clinical tests that should be used to assess protective sensation, large and small fiber function include, of course, for small fiber function, the pinprick and temperature sensation. For large fiber function, vibration perception with your 128 Hz tuning fork or your 10 gram monofilament may be used there. And for protective sensation, your 10 gram monofilament. Now, you've already covered the foot examination, which covers vibration perception, 10 gram monofilament use already, so we're not going to go through that. Instead, what we're going to focus our time on here is on the symptoms of diabetic peripheral neuropathy and decide whether it would be large myelinated fibers or small myelinated fibers. Right. So when it comes to large myelinated fibers, in terms of function, they are there for pressure and balance, and the symptoms that the patient will experience include numbness, tingling sensations, of course, poor balance. And the examination there, you might find a reduced ankle reflex, vibration perception may be reduced or absent, 10 gram monofilament test may be reduced or absent, and proprioception may be reduced or absent. When it comes to the small myelinated fibers, they are responsible for pain perception and protective sensation perception. Here what will happen is the person will experience burning, or of course electric shock sensations and stabbing sensations in their limbs. And the examination here will be thermal discrimination, either by cold or by absent, and of course pinprick sensation may be reduced or absent. Thermal discrimination is a very easy test to do. You will generally apply something warm and then something cold. You'll ask the person to close their eyes and tell them to describe what they're feeling. Ask them to describe what they're feeling rather. So remember that the diagnosis, 128 Hz tuning fork is used to assess vibration perception. An assessment of light touch can be done using a 10 gram monofilament and should include the dorsal aspects of the great toe or the big toe bilaterally. 10 gram monofilament is a clinical tool used for detecting advanced neuropathy and identifying patients at risk for developing diabetic ulceration or having amputation, and that is primarily why it's one of the tests that we use in diabetic foot disease. Combining two examinations increases the sensitivity and specificity of detecting diabetic peripheral neuropathy. Right. A large body of evidence exists for supporting pharmacological management of neuropathic pains using different classes. The classes that we sometimes consider talking about include the anticonvulsants, the SNRIs, the tricyclic antidepressants, and of course the opioids. Right, glycemic control for diabetic peripheral neuropathy is of utmost importance. Right, enhanced glucose control in patients with type 1 diabetes reduces the incidence of diabetic peripheral neuropathy, and there's a relative risk reduction here of approximately 78%. So there's an extreme relative risk reduction here just in type 1 diabetes with enhanced glycemic control. Better glycemic control in type 2 diabetic patients only has a moderate reduction or moderate relative risk reduction in diabetic peripheral neuropathy, anywhere between 5 and 9%. And of course, type 2 diabetes may develop type 2 diabetic patients may develop diabetic peripheral neuropathy despite adequate glucose control, and that's something you need to take into account, that patients may not always have poor glycemic control and have diabetic neuropathy. But, and this is very important to suggest, if the person does have poor glycemic control, they will most definitely develop diabetic peripheral neuropathy. But if they have good glycemic control, can go either way. Lifestyle interventions. The best model for lifestyle interventions comes to us from the DPP, the Steno-2 study, and the Italian treadmill, and the University of Utah type 2 diabetes study, which suggests that exercise, both supervised aerobic and resistance training, is very important, right? Combined dietary modification and exercise is equally important, and considering a low calorie, low fiber or Mediterranean diet that is moderately lower in carbohydrates, about 45%, higher in good fats, 30 to 45%, with less than 10% coming from saturated fats, will in some way reduce the risk of diabetic peripheral neuropathy and diabetic neuropathy in general. So, in terms of the anticonvulsants, both gabapentin and pregabalin have been investigated to treat painful diabetic neuropathy. Pregabalin is effective in the management of neuropathic pain associated with diabetic peripheral neuropathy. The majority of trials for these agents have been positive, producing at least a 30 to 50% improvement in pain in patients with painful diabetic peripheral neuropathy. Not all trials, however, were positive. Pregabalin is preferred to gabapentin because it has a linear dose proportion absorption in terms of therapeutic dosage range, and patients also have a rapid onset of action in terms of pain relief with pregabalin, and pregabalin requires less dose titration. Now, essentially what I want you to get from this particular slide here is the dosing intervals that we may need to use for these particular drugs, because I may ask you specifically about the dosing interval of pregabalin or gabapentin in a patient with diabetic peripheral neuropathy, as well as you may just need to take into account the potential adverse effects that may occur with them, although I'm not going to focus too much on the adverse effects. When it comes to pregabalin, right, your initial dose should be anywhere between 20 to 75 milligrams once to thrice a day. Usually you'll start off with about 25 milligrams and you'll slowly dose upwards towards the effective dose, which is anywhere between 3 to 600 milligrams daily. Right, and you may note that the patients may complain of somnolence, dizziness, peripheral edema, headaches, ataxia, xerostomia, and weight gain. Some patients may have angioedema, which can be extremely severe, hepatotoxicity, rhabdomyolysis. They may have suicidal ideation, and seizures may begin after rapid discontinuation, and they may also have thrombocytopenia. When it comes to gabapentin, for example, you want to start at 100 to 300 milligrams 1 to 3 times per day and dose completely up to 900 to 3600 milligrams per day. It is associated with somnolence, dizziness, ataxia, and fatigue, and it's one of the drugs that is associated with Stevens-Johnson syndrome. It also causes suicidal ideation and behavior, and of course seizures can occur after rapid discontinuation. Now, SNRIs, duloxetine and venlafaxine were trialed and found to be effective in managing painful diabetic neuropathy. Duloxetine you want to use at a dose of roughly 60 to 120 milligrams daily, as demonstrated to be effective in clinical trials. Some of these trials had a high dropout rate, which obviously limits the validity of the results, right? And venlafaxine at a dose of 150 to 225 milligrams daily has been demonstrated to be effective in clinical trials. Duloxetine seems to be more effective than venlafaxine. Again, dosing here very important to know, and choice of drug very important to know here. Right, when it comes to tricyclic antidepressant, recent Cochrane reviews have criticized utilizing tricyclic antidepressants in the management of painful diabetic peripheral neuropathy. Authors have questioned the quality of the evidence on amitriptyline due to concerns regarding bias given the small sample sizes that were used in the clinical trial, and the authors concluded that there was a lack of clear evidence suggesting the benefit of using amitriptyline in these patients. So as far as possible, you should either use an SNRI like duloxetine, for example, or alternatively you should use an anticonvulsant like pregabalin, for example, over using a tricyclic antidepressant. But you may still need to give the patient some kind of pain relief. Now, tramadol has been demonstrated to show some effectiveness in clinical trials, and guideline authors suggest that it should be considered as a second or third line agent. Right? So, tramadol may also be considered as an add-on agent as far as I'm concerned, and you start off at a dose at 50 milligrams once to twice a day, and you can go up to 210 milligrams per day, right? And of course, it does cause somnolence, it can cause nausea, vomiting, constipation, lightheadedness, dizziness, and headaches. And its major adverse effects include confusion, seizures, arrhythmias, hypertension, hypersensitivity reactions, and of course, Stevens-Johnson syndrome. Right, the next thing we're going to discuss is diabetic autonomic neuropathy. So what are the signs and symptoms of diabetic autonomic neuropathy? Well, they include hypoglycemic unawareness, resting tachycardia, orthostatic hypotension, gastroparesis, constipation, diarrhea, fecal incontinence, erectile dysfunction, neurogenic bladder, and pseudomotor dysfunction with increased or decreased sweating. Now, we're only going to go through a few of these, right? We're not going to go through every single one. First one we're going to discuss is cardiac autonomic neuropathy, which is associated with mortality independent of other cardiovascular risk factors. The early stages, cardiac autonomic neuropathy may be completely asymptomatic and detected only by a decreased heart rate variability when deep breathing. In the advanced stages of the disease, you will have tachycardia and orthostatic hypotension. Right, and of course the treatment is actually symptom alleviation, and most patients require non-pharmacological and pharmacological measurements. Now remember, when we are trying to look specifically at cardiovascular autonomic neuropathy and we're looking at orthostatic hypotension, we are looking at a fall in either diastolic or systolic blood pressure of by 20 millimeters per mercury or 10 millimeters per mercury or more when moving from a supine position to a standing position without an appropriate increase in heart rate. Right, the non-pharmacological measures could be ensuring adequate salt intake for orthostatic hypotension, avoiding any kind of factors that aggravate the hypotension, like getting out of bed too quickly, for example. Usually doing it very slowly may be helpful. Compressive garments may be useful over the leg and abdomen to reduce the amount of blood pressure droppage as required, and physical activity and exercise should be encouraged. Supine blood pressure tends to be much higher in these patients, and their supine blood pressure may require some treatment with blood pressure medication, particularly at bedtime, with short-acting devices that affect the baroreceptor. So there we're looking at something like clonidine, which is very short-acting, or atenolol or metoprolol can be used. Enalapril can be suggested in patients who are unable to tolerate these agents, but remember that enalapril itself is associated with hypotension, and therefore the preferred agents are either clonidine, atenolol, or metoprolol. In gastroparesis should be suspected in individuals with erratic glycemic control and upper GI symptoms, and you need to exclude causes of gastric outlet obstruction or peptic ulcer disease. Right? And the diagnostic gold standard for gastroparesis is the measurement of gastric emptying with scintigraphy and digestible solids at 15-minute intervals for at least 4 hours. And you can, of course, use carbon-13 octonic acid breath test instead. Now, the treatment for gastroparesis is quite complex. You generally need a low fiber, low fat eating plan provided, and there must be small frequent meals with greater proportion of liquid calories. Withdrawing drugs with adverse effects on GIT motility, particularly those ones that slow GIT motility, like opioids, anticholinergics, tricyclic antidepressants, and we may even need to stop GLP-1 receptor analogs. And then we can either treat with metoclopramide, domperidone, or erythromycin, because all of these will hasten gastric emptying. The preferred treatment, of course, is either metoclopramide or domperidone. Metoclopramide at a dose of 10 milligrams TDS. We can generally try, but these can only be used for a period of maximal 12 weeks. Right, the next thing we're going to discuss is sexual dysfunction. And of course, diabetic autonomic neuropathy may cause erectile dysfunction or retrograde ejaculation in men. Female sexual dysfunction occurs more frequently in those with diabetes than those without diabetes. And female sexual dysfunction will present as a decreased sexual desire and increased pain during intercourse, decreased sexual arousal, and inadequate lubrication. Right, and the treatment for males especially includes phosphodiesterase 5 inhibitors, intercorporeal or interuterine prostaglandins may be useful, vacuum devices or penile prosthesis. In the case of females, you may have to look at estrogen as a way in which to help them. But ideally, the most important thing is glycemic control here. Interventions do not change the underlying pathology and natural history of the disease progression, but may only improve the patient's quality of life. And that is essentially true. All we're going to do in these scenarios is improve the patient's quality of life. And we've come to the end of this lecture. Hopefully it's been an interesting and fruitful lecture for you, and you've learned quite a bit from this particular experience. The last lecture left now in this series is, of course, the lecture on cardiovascular disease and diabetes, and then we'll move on to the other endocrine disorders. Thank you very much for your time.